Well, a very good evening to each and every one of you. This is a very special program that we're going to be entering into this evening. I trust that you're prepared for what is just ahead. As a matter of fact, we know that you will be feeling kind of inundated and overwhelmed with all of the COVID talk, but we don't want to look at COVID-19 from the usual point of view. We want to give you some tips so that you can understand more about it and that you can work with it at your leisure in your time, preparing for it and how you can protect both yourself and your loved ones. All right, so this evening we have the first Dr. Selwyn Greenidge, and he's going to take us through this important presentation. And at the end of the presentation, there will be time for questions. So if there are any questions you can that you have, you can write them down. And those who are on Facebook or on YouTube, remember, write down your questions, and you can always send them in for them to be answered. All right, so at this time, we are going to pray to open, and we're going to invite Dr. Greenidge to come on and address us. Dr. Greenidge, can you please turn on your video? All right, good. All right, so Dr. Greenidge, are you ready? You can put on your mic.
Yes, I am.
All right, good. So we are ready for this journey, and what I'm going to do at this time, I'm going to hand over to you, and you can prepare us for the presentation with a word of prayer as you look at this issue. All right, so I hand it over to you at this time. Allow me to spotlight you.
Thank you, Brother Leach. Let us pray at this time. Dear loving Heavenly Father, we thank you at this time for the privilege and the blessing of life and health and strength as we live as it were in the shadow of this pandemic that is costing lives and livelihoods. We are happy that we have been given the privilege of rejoicing in your name, of enjoying the blessings that you have for us, not because we are more deserving than those who may be suffering, who may be infected or affected, but because of your mercy and your grace. And therefore, as we conduct this session, we ask for your guidance and your protection, and that you will enlighten our minds regarding the things we ought to know, the things we ought to do to protect ourselves, our families, our communities from coming to harm. As you promise in your word, 1,000 will fall at thy right hand and 10,000 at thy left, but the plague shall not come nigh thee. We want to claim this promise this evening. So into your hands we commit ourselves. In Jesus' name.
Amen.
Well, as you can see on the headline slide, this session is called Demystifying COVID-19 Disease, and I put in brackets for the layperson, and this is only part one. So COVID-19 is probably the greatest public health challenge in modern history. It is a very complex and complicated illness, a very complex and complicated pandemic. And I know, therefore, that many people, in spite of being inundated with data and information, some people may still be confused, may be fearful, and so on. And the objective of this series, therefore, is to alleviate the fear and the confusion by shedding light on this very foreboding condition. This is only one of a series. And as it is said, a journey of 1,000 miles begins with the first step. And this evening is just the first step. Now, we will not cover the entire spectrum of conditions. We will not cover the entire disease, treatment, and so on in this session. However, what we hope to do is lay a foundation that will serve to enlighten you enough so that when we take the next step, you will still be in tune with what is happening. It's not our desire to diagnose or treat any condition in any particular individual. This session is meant purely and simply to inform, to encourage, and to enlighten. So without much further ado, I'll press right ahead. Demystifying COVID-19 disease. Now this slide that you are seeing, if I can ask my moderator to just put up the second slide. Right. This slide that you are seeing now is 1 week old. I did not have the opportunity to update it, but it more or less tells the picture. And we see the state of things as they were 1 week ago. We know they are worse now. Up to that time, we had in Barbados a total of 15,341 total cases recorded. At that time, there were 794 individuals in isolation facilities and 4,514 in home isolation, with 2 new deaths at that time. I believe the death count has risen to north of 150. So that is something that is available to everyone generally, and of course on the world stage as well. We know that we've already surpassed the number of deaths that were recorded for the famous 1918 flu pandemic. Over 4 million deaths reported or attributed to COVID-19. Next slide. So the objective of this particular segment is to make the complex virology and pathophysiology of the novel coronavirus 2019 simple. That is it. Because I know that I am dealing largely with lay persons, and therefore I want to make sure that each and as many persons as possible understand the mechanics, the science behind this virus and this pandemic. So the contents of this section will be purely the virology of the novel coronavirus 2019 and the pathophysiology of COVID-19, or at least some of the pathophysiology, because we would not be able to cover all of that today, but so much as to give you a foundation to understand further. What is virology? Virology is the scientific study of viruses. We know that we speak as laypersons about bugs, about germs. Bugs are just a general term for things that annoy us. So whether they be viruses, bacteria, or cockroaches, we call them bugs. But germs are basically, quote unquote, bugs that we cannot see with the naked eye. So an important distinction that we need to be clear on, I believe most persons are, but for the sake of completeness, I will reiterate the fact that viruses are not bacteria. Bacteria are not viruses. Therefore, what is a virus? Viruses were discovered in 1892, I believe, by a Russian biologist by the name of Dmitry Ivanovsky. They are not living organisms. I'm going to ask Brother Leach to please share that slide to the audience. They're not living organisms. The next one, please. They lack cellular structure. So viruses, unlike bacteria, unlike higher order creatures, do not have a nucleus. They do not have mitochondria to produce energy. They do not have what we call ribosomes to translate RNA script into proteins. They're transmitted through vectors. For example, the dengue virus is transmitted to humans via a mosquito vector, the Aedes aegypti mosquito. And viruses use target or host cells as virus factories. They use host cells or target cells as virus factories. Viruses are very specific. Viruses tend to affect specific species. They tend to affect specific organ systems and cells depending on the particular receptor that the virus is attuned to. So what the virus does, it causes the host cell to make many virus copies very rapidly. So viruses essentially are obligate intracellular molecular parasites. What that means, parasite, they depend on other organisms to live and to flourish. And they do that by existing inside that organism. And that obligate because that is the only way they can survive. Next slide. So the next slide, I'm highlighting the differences between bacteria and viruses. And please bear with me because there are some key points that will become very significant, not only in this session, but in subsequent sessions. Differences between bacteria and viruses. So on the left, you'll see a column with the characteristics, distinguishing characteristics of bacteria. On the right, a column with the distinguishing characteristics of viruses. And we see that bacteria are able to copy themselves, while on the other hand, viruses cannot copy themselves. Bacteria are able to make their own proteins, while the viruses cannot make their own proteins. Bacteria produce their own energy, while viruses cannot produce their own energy. And if we look under a light microscope, we are able to see a bacterium. But you cannot see a virus under a light microscope. You need an electron microscope for most viruses. And while a bacteria, one bacteria divides, multiplies, or reproduces by dividing into two, one virus in a whole cell replicates by producing billions or even trillions of copies of itself in one single cell. In bacteria, proteins are abundant, while in viruses, there are few. So viruses just have the bare essentials, and therefore enzymes, which are proteins, are abundant in bacteria, but very few in viruses. A critical point is that bacteria do have mitochondria, which are the energy-producing organelles inside of cells, while viruses do not have mitochondria, so viruses cannot produce their own energy. In bacteria, as we said before, ribosomes are present, while in viruses, ribosomes are absent. So they cannot reproduce, viruses cannot reproduce themselves. They cannot replicate their own DNA on their own. Bacteria will contain DNA and RNA, deoxyribonucleic acid or ribonucleic acid, while viruses may either contain DNA or RNA, generally speaking, because we have DNA viruses and RNA viruses. Now, the SARS-CoV-2 virus happens to be an RNA virus. So continuing to look at the virology, we just want to see where the SARS-CoV-2 virus fits in. Now, there are countless numbers of viruses, and there is a particular family of viruses called the coronaviruses. I'm asking Brother Leach to just keep the slides flowing. So we have the Coronaviridae family, and in that family, one of the subfamilies is the coronaviruses. And we can see there are 4 genera or 4 subgroups of coronaviruses. We have alpha, beta, gamma, and delta coronaviruses. And of course, the SARS-CoV-2 virus is a beta coronavirus, just like the SARS, the original SARS virus and the MERS virus. They are beta coronaviruses. And we know that in previous coronavirus pandemics that we've had. Oh, by the way, I should say that coronaviruses constitute a fairly large segment of the viruses that cause the common cold. So you see that they're fairly widely in terms of their ability to cause disease and illness. So comparing the SARS-CoV-2 virus, which we are experiencing right now, the novel coronavirus 2019 with previous coronaviruses, we see that the first SARS-CoV as the SARS-CoV-1 virus of 2003 had as its primary host a bat. And that bat transmitted the virus via an intermediate host, namely a civet cat, which in turn transmitted it to humans. And that has been well documented by virologists. Then in 2012, we had the MERS coronavirus, or the Middle Eastern Respiratory Syndrome coronavirus, which was transmitted from the primary host, which would have been a bat, to the intermediate host, which was a camel, which in turn transmitted that to humans again. And now we have I'm going to ask Brother Leach to shift to the next slide. Thank you very much. So what we're talking about would be to the left of the present slide, SARS-CoV-1, MERS, and then the final one would be the SARS-CoV-2 virus of 2019, which we know originated in bats, which originally it was thought was transmitted through the name of that organism escapes me right now. I believe it was, the name escapes me. Anyway, the point that I'm making is the pangolin. The pangolin, right. The point I'm making is that up to this point in time, scientists, virologists have not been able to confirm conclusively what animal is the intermediate host for the SARS-CoV-2 virus between bats and humans. But that is a discussion for another time. Next slide. So what I want to illustrate with this slide, and this slide is outdated, it's from the 27th of February 2020, which was last year. And this just serves to demonstrate how lethal the current SARS-CoV-2 virus, which causes COVID-19, is compared to the previous coronaviruses and compared to Ebola. We see that the original SARS infected 8,098 cases in 2002 and only caused 774 deaths, or had a mortality rate, a case fatality rate of 9.6%. In 2012, the MERS virus infected 2,494 cases and caused 858 deaths. That is, it had a case fatality rate of 34%. The COVID-19 virus, however, and these figures would by now be outdated, has by now infected millions of cases and has already passed the 4 million mark in terms of case fatalities. So even the Ebola virus was more fatal than MERS and SARS, but certainly not as fatal as, the Ebola virus was more fatal than the COVID-19 virus, but it has not affected as many people. Thank God for that. Next slide. Right, so this slide just shows a total number of cases up to a week ago for COVID-19. The total number of deaths would be the fourth line from the top. At that time, it was 4,959,363, with a case fatality rate ranging from 1.38 to 3.4%. Next slide. Oh, before we go to the next slide, just highlighting the fact that at-risk groups initially, at least with the alpha variant of this virus, were adults 65 years of age and older, and people of all ages with underlying medical conditions. Next slide. Right. This is just a slide of the influenza pandemic of 1918 for comparison, showing that it killed over 50. Now, I don't think that, I'm going to ignore that slide because I think these figures may be erroneous, so I'm going to scratch that. The next point I want to make is that COVID-19 is by no stretch of the imagination the flu. All right. First of all, and I'm going to demonstrate this with two slides. The first slide that you're seeing here shows what they have in common. So both the flu and COVID-19 are transmitted by respiratory droplets from an infected person. Both may cause a fever, a cough, fatigue, you know the usual aches and pains, what the old people call the ague. But they differ in several respects. First of all, the symptoms of the flu begin 1 to 4 days after exposure to the virus, the influenza virus. While the symptoms of COVID-19 may begin a day or as long as 14 days after exposure. The influenza virus is the cause of the flu, as we know, and there are many strains. It mutates fairly rapidly, which means that every year a new vaccine has to be created for that particular condition. While, of course, we know that the COVID-19 disease is caused by the SARS-CoV-2 virus, which subsequently has produced a number of mutations or variants. And we are currently under the effect of the Delta variant, which is proving much more transmissible than the Alpha variant. Complications of the flu, less likely to occur because of immunity built up over time. And that is, of course, except in very vulnerable groups. While for COVID-19, you can have severe respiratory complications, which may come on extremely quickly. Next slide. And if nothing convinces you of the difference between the flu and COVID-19, it is these death charts here. This shows the death rates by age group compared between the flu and COVID-19. And you will see on the left, for all age groups, the flu has significantly lower mortality rates than COVID-19 on the right. So just to illustrate that COVID-19 is not to be taken lightly by no stretch of the imagination. Next slide. So now we're going to zero in on the structure and functions of the SARS-CoV-2 or novel coronavirus. Next slide. This is a slide I pinched from a magazine online, and it shows basically the structure of the SARS-CoV-2 virus cut in half and looked on end on. And you'll see that the virus is spherical in shape, and inside that sphere, you will see a red chain of what is the RNA of the virus. So the red chain inside the sphere, inside the ball, is the RNA of the virus. And then you will notice some blue structures that are entangled with that red chain. And these are what we call nucleocapsid proteins, which help to stabilize the RNA, the genetic code of the virus. And then the ball itself is encased in a lipid bilayer. It is encased in a fatty, for want of a better word, a lipid membrane. In that membrane are a number of protein structures, structural proteins. And you will see most prominent of all the large club-shaped orange structures are the famous spike proteins, or S proteins, which we will learn about some more shortly. You will also notice, you will see an M protein, which is color-coded purple, and an N protein, which is colored in blue as well. Sorry, the blue is a nucleocapsid protein. The E protein, or envelope protein, is in yellow. These are very important structures. And even if you're not a virologist, knowing something about them will greatly increase your understanding of why this virus is so lethal. Next slide. Right. Now, I did not put this slide here to kerfuffle anyone, but rather than attempt to describe the structure of the virus and the nature of the proteins that are encoded by its RNA from scratch, I thought a picture would help. So on the top of this slide, you will see another representation of the SARS-CoV-2 virus with the protein structures that I mentioned earlier, the structural proteins. Underneath is a representation of the RNA code for that virus. And you'll notice that 2/3 of that RNA code, the RNA code for the SARS-CoV-2 virus consists of about almost 30,000 kilobases, which would be the units that are used to code for amino acids. About 30,000. A human being has 46 chromosomes. So here we have a virus with a very small amount of RNA genetic code, which is running rings around 7 billion people, 8 billion people, with 42 chromosomes. Quite remarkable. But if you take a look at that RNA strand, you will see that there is a yellow strip representing what we call non-structural proteins. And then at the end, you will see 4 reddish colored strips representing the structural proteins on the virus itself. And these are very important because they play an important role not only in we know that the spike protein plays a very important role in the virus gaining access to the cell. The other proteins, the envelope protein, the membrane protein, and the nucleocapsid protein play important roles in disabling our immune system once that virus gains access to the cell. Next slide. So this is just a slide giving a short snippet on what these different structural proteins do. I am going to slide right along in the interest of time. So I'm going to ask you to shift to the next slide. This basically represents the 2 slides ago. Next slide, please. Right. So having given a primer on the virology of SARS-CoV-2, what we're going to look at now is the pathophysiology, at least part of the pathophysiology, because I cannot do it comprehensively. So pathophysiology, as we see, is a physiology of altered health states, specifically the functional changes that accompany a particular injury, syndrome, or disease. So we have physiology, which is the normal functioning of the organism. Then we have pathophysiology, which is the altered functioning of the organism when it is diseased. And it comprises of two components. First, it relies on an understanding of human physiology. So a person must first understand how something works normally before grasping what occurs when something goes wrong. And of course, the pathophysiology is the second component is looking at how the pathophysiology is based on functional changes in the body. So this has to do with how the body responds to disease. In this case, viral infection. Next slide. Now, I just want to spend a short period I just want to spend a short time looking at transmission, because I want to emphasize the importance of the non-pharmacological measures that have been implemented to prevent transmission of the Sars coronavirus, such as social distancing, mask wearing, personal hygiene, washing of hands, sanitizing, and so on. Because if you understand how the virus is transmitted and its pathophysiology, then you will understand why these measures are important, even though they were not all universally emphasized at the beginning of this pandemic. Now, this slide shows, for example, two persons, an infected individual on the left and a susceptible host on the right. And you will see illustrated the three proposed means of transmission of the SARS-CoV-2 virus. You will see, and let me start with the bottom, that the SARS-CoV-2 virus can be transmitted through objects that an infected person contaminates, and then which is subsequently handled by a non-infected or susceptible host. These are called Formites. It's a term of art in medical science, just to describe objects that may be a focus of infection. So you're talking about doorknobs and door handles and railings on stairs and things of that nature, but also movable objects that we may share. Money, for example, can be a Formite, and so on. So you get the general idea. The viral particles can be transmitted through objects that we handle in common and share. But it is a respiratory virus, and what shall I say? It sort of crowds or inhabits the respiratory tract, and especially the upper respiratory tract, the nose, mouth, and throat. And therefore, the virus can be transmitted by droplets or by aerosols. What do we mean by droplets and aerosols? Now, these are just arbitrary terms that are used, but they're useful. For example, a droplet is usually, for example, if someone coughs, they may release droplets of saliva, of mucus that are more than 5 microns in diameter. 5 microns, what does that mean? That is about a thousandth of a meter, very small. And because of their weight under gravity, they usually are only able to travel less than 6 feet. But then you have aerosols, which are much smaller particles, less than 5 microns in diameter, and can travel beyond 6 feet. This is important. And it has been demonstrated actually that both of these methods of transmission are important. For example, in one study of passengers traveling on a train, it was demonstrated that passengers who were closer to an infected host were more likely to become infected, were more likely to be diagnosed COVID-19 positive than those who were at a distance from the host, from the infected individual. And this is a classic study of passengers traveling on a train, I believe, in China. Another important study would have been the tale of 2 cruises, where one cruise liner had passengers who wore no mask, while a second cruise liner had passengers who all wore masks. And it was found that among those who wore no masks, large numbers of people became infected. Only 20% of them were asymptomatic. While in the cruise liner, where passengers all wore masks, a significantly lower number were infected. And I believe of those, 80% were uninfected, were asymptomatic of those who were infected. So just those 2 things to emphasize the importance of social distancing, hand washing, wearing masks, and so on. I'm going to ask Brother Leach to shift 2 slides forward in the interest of time. 2 slides forward, please. Next slide. Right. So this slide shows the key phases of disease progression when someone is infected with COVID-19. Now, we know that, as I said before, viruses are very specific. They target specific species, they target specific cells, and the reason they're able to gain access to these cells is because these cells have what we call receptors on their surface. A receptor is like a lock, which, if you're able to unlock, gains you access to the cell. The coronavirus has the key to that lock. It is the spike protein. And ACE2 receptors, as they're called, are distributed fairly widely in the body. In fact, before the advent of COVID-19 and before studying its pathophysiology, I was not aware that an ACE receptor was so widely distributed in the body. But it is connected to other processes that are unrelated. But the SARS-CoV-2 virus happens to use it to gain access to cells. And in this slide, we see that severe acute respiratory syndrome, or SARS-CoV-2, binds to the ACE2 receptor, for short. The initial infection of cells in the upper respiratory tract may be asymptomatic, but these patients can still transmit the virus. For those who develop symptoms, up to 90% will have pneumonitis caused by infection of cells in the lower respiratory tract. Some of these patients will progress to severe disease with disruption of the epithelial barrier. And what that means, what that is referring to, is the boundary between the cells in the alveoli of the lung and the blood vessels with which they exchange oxygen. And beyond that, so the epithelial barrier is referring to the boundary between the lungs and the blood vessels. But the virus goes beyond that barrier and it can gain access to many other organs in the host. So on this slide, you'll see on the extreme left that the SARS-CoV-2 infects ACE2 expressing nasal epithelial cells in the upper respiratory tract. What does that mean? In the upper respiratory tract, we have cells that line that area. And these cells have on the surface ACE2 receptors or locks to gain access to cells. The virus has the key to unlock the cell and gain access in the upper respiratory tract. And in fact, the upper respiratory tract is more laden with these locks, these ACE2 receptors, than even the lower respiratory tract. So the upper respiratory tract, meaning the nose, primarily the mouth, the throat, but primarily the nose, is swarming. In an infected person, they're swarming with SARS-CoV-2 viruses. This is very important when it comes to prevention, when it comes to simple treatments that can be administered to minimize the impact of the virus. But beyond this, the virus, when we aspirate mucus and so on into the lungs, we are also aspirating some of that virus. So the virus is then able to infect cells in the lungs and cause a pneumonitis, that is an inflammation of the lungs. And then beyond that, we have severe disease. 7 to 10 days later, when there's involvement of, or rather disruption of the lining, the barrier between the lungs and the blood vessels. And we get, as a result of that, an hyperinflammation. In other words, an exaggeration of the normal inflammatory reaction that our immune system would normally exhibit, and so on. And we get what we call complement deposition, we get excessive clotting, and so on. But an important thing I want to highlight to you before we progress from here, and I'm going to have to move at warp speed to complete this presentation. What I want to highlight to you is this. Your immune system has two arms. There is the innate immune system, which we are born with. And then there is the adaptive or specific immune system, which is enhanced over time as we encounter infectious agents and so on. A virus, when we're infected with a virus, when that virus enters a cell, it activates the cell's innate immune system. What does that mean? It means that the cell sounds an alarm. it sounds an alarm. And that alarm is the release of something called interferon, which signals to nearby cells and to the body's immune system that the body is under attack and we need reinforcements to help. And what is going to happen is that the cell, the immune system will send what we call macrophages. It will send what we call non-killer T cells to deal with the invader. Remember I said earlier that the SARS-CoV-2 virus has, in addition to the spike protein, some other structural proteins which which disrupt this aspect of the innate immune system. In other words, the SARS-CoV-2 virus disables your body's ability to sound an alarm so that COVID-19 often progresses covertly by stealth before we even begin to get significant symptoms. It is progressing. And therefore, we need to be very vigilant. We need to be very aware so that it does not steal a march on us. I'm going to ask Brother Leach to fast forward to the slide that says hijack. The slide that says hijack. Right, there you have it. We're going to close off just now. We're not going to burden the saints. This is a simple slide that shows what happens when the virus enters the cell. I'm going to try to simplify it as much as possible for you. So basically what you're seeing here is the virus latches on to that ACE2 receptor, unlocks the cell, and you also see next to it a structure called TMPRSS2. It sounds like too much in the mouth and too much to put in your brain, but it is very important for future reference. This, I'll call it TM for short, helps the virus having latched on to the ACE2 receptor to gain access to the cell. Once the virus is in the cell, it's enclosed in a bubble of lipids, for example, and then it gains access to the cell's protein making apparatus. So what happens is that once that virus is inside, that one virus is inside the cell, the RNA is multiplied, is copied many times, and also the RNA is translated into the viral proteins. And these viral proteins and these multiple copies of RNA are reassembled into billions and even trillions of new brand SARS-CoV-2 viruses. And because the innate immune system has been disabled, the cell is not destroyed before these viruses can be released, so that the virus gains a march on us. So I'm going to elaborate on these in the next segment, but essentially, it is because of our quite variable response to this virus that we get such a wide spectrum of illness on exposure to the SARS-CoV-2 virus. I want you to go to the final slide, Brother Leach. The final slide, please. Right, that is it. This is the slide on which we will close and pick up on next time. So basically, on exposure to the SARS-CoV-2 virus, either two things are possible. Either we are not infected or we are infected. If we are infected, two things are possible. We can be asymptomatic or symptomatic. If symptomatic, we may either have mild illness and recover, or we can have mild illness that progresses to moderate illness, and we can then recover at the moderate stage, or we can have moderate illness that progresses to severe illness, from which, or we can go straight to severe illness, from which we may recover or we may die, depending on how our immune system is able to act against this invader. And there are many variables at play. And the next time we speak, we will look a little more at pathophysiology. We will look at who is more susceptible to severe illness in COVID-19. We will look at the factors that determine who will be asymptomatic, who will be mild, who will be moderate, and who will be severe. So this is purely a foundation. So my apologies to those who may have been looking for some practical tips today. Unfortunately, we will not be providing those as yet. We just wanted to lay a foundation for future reference. So with that, I will close off. Thank you very much to the audience. I hand over to the moderator, Elder Leach.
Well, yes. Well, I would like to thank you very much, Dr. Greenidge, for that extremely informative presentation. As a matter of fact, there are things that were said in that presentation that caused me to understand what actually is going on in the body. Sometimes when you see it like this, it causes you to realize, okay, in picture form, as it progresses, you can identify what is happening and therefore can give you an idea as how you can work with the situation. So I don't know if any person has any questions for Dr. Greenidge at this time. He did not go very far into or mention much concerning the tips that can be used for assisting and protecting you and your family, but that is going to come in subsequent programs. But based upon the presentation today, the question is, do you have any, based upon the program now, do you have any questions? Was there anything that was not clear that you would like cleared up in your mind to understand more about the very structure of COVID? Any questions or any comments?
Hello, good evening.
Hi,
This
good
is
evening.
Sister Kiso.
Hi, Sister
Hi,
Kiso.
everyone. Well, of course, you all know that our family has been hit with the COVID. But what I see is actually, now I came on to the meeting very late. I came on very late because one of my son is has now been affected. So I was just taking care of him. So, but what I am experiencing in the evening is that I'm getting mild fever and very mild headaches as the evening comes on. And today is actually day number 4 of me taking the high dose of ivermectin. So I don't know what I can do to really overcome that, discomfort.
Dr. Greenidge.
That's it.
Okay. Right. So, hi, Sister Kisto. Thank you very much for the question. Now, as we said, the program is not intended to prescribe or treat. Therefore, I will have to address that question privately, one-on-one. Okay? If you can appreciate that. Hello?
No problem. I'll definitely appreciate it. Sure.
Okay.
All right.
Okay.
Yeah. Yeah.
Just a brief comment. Dr. Greenidge, thanks very much for a very good presentation. I really enjoyed it. You mentioned about asymptomatic persons and persons with mild symptoms, and also that persons can even transmit the virus before they have any symptoms. And I think that this is very important for persons to understand. And I think a lot of persons are afraid to go for testing when they realize that they've come in contact with an individual who's positive. And as Sister Kisto is saying, you know, some persons can have fever, some persons can feel really ill. So I don't think we should avoid going for testing. As long as you come in contact with a positive case, you should go for testing, because you don't know, as you would go into next week, you said who would be severely ill or who would be mildly ill or moderately ill. So I just want to re-emphasize that. Thank you.
Thank you very much, Sister Carmita. It is very important to know as early as possible what your status is so that you can intentionally address it. It is like if you're in a dark room and a mosquito starts buzzing around, as I used this illustration before. Are you going to try to swat that mosquito in the dark, or are you going to turn on the light so you can see the mosquito so you can swat it? So let's not be groping in the dark and grasping at shadows, but let's know what our status is so that we can treat it as early as possible. And I know that I did not address symptoms today. I believe that with all of the media coverage and so on, you're probably inundated with the symptoms of COVID. And we're going to address this next week. I've also come across in my following and even in my private practice some very atypical symptoms of COVID, which I'm going to enlighten the audience about as time goes on. But I'm going to leave more time for questions right now.
Yeah, and Dr. Greenidge. Dr. Greenidge?
Yes.
Right. You had made a very important contrast between the flu and COVID. Now, only today I had spoken to some person who was referring to COVID as the flu. So, is it possible that you can emphasize that point, that COVID is not the flu, just one more time? And why is it not the flu?
Well, first of all, COVID-19 is the flu. Flu is caused by the influenza virus, which is a DNA virus. And it has the onset of symptoms are much earlier after exposure. And it tends to affect a particular segment of the population. Those who are older tend to be affected more. Those who are immunocompromised, of course. However, COVID-19 is caused by an RNA coronavirus, and it is a vastly more complex and complicated disease than the flu. It operates very stealthily. It moves very covertly because it is able to disarm and disable your first responders, the innate immune system. And it does its damage under the cover of darkness, so to speak, so that you can catch it too late. So I cannot emphasize enough the importance of being knowledgeable, being vigilant, and being prompt in acting with regard to COVID-19. In other words, we must, if the symptoms are doubtful or dubious, we must have a very high index of suspicion for COVID-19 in the midst of a pandemic of COVID-19.
Would you say that sneezing is one of the symptoms of COVID-19?
It is not a very common symptom, but it may occur with COVID-19. Yes, it is a possible symptom, but it's not one of the most common ones, as far as in my experience at least.
Okay, are there any other questions from anyone before we wrap up? Thanks to Sikiamita Duglin for her contribution there. It is critically important. I would like to emphasize the point for us to be tested early. Early detection, early treatment can save lives. Early detection, early treatment. That is exceptionally important. All right? So testing is critical. If you know that you have been in contact with some person as a primary contact, there's nothing, you should go and get tested. I was not interested in getting tested, not until I sneezed the other day, and I said to myself, well, yes, I'm not going to go and get this test. The doctor told me, yes, go and get tested. I listened to the doctor, and I came up positive. All right? And this program is being recorded. It's being recorded on my Facebook, Demetrius Leach, and it's also being recorded on YouTube, TJAB-BDS. You can go to any one of those platforms and you can find this recording there if you want to review it. And if you want to get in contact with Dr. Greenidge, if any person wants to get in contact with you personally concerning any information, what is the number that they can connect, or how will they be able to connect with you?
Okay, I can reach at 850-7392. 850-7392. With regard to the last point you made, I have to emphasize this, that it is possible to have a false negative PCR test as well. Just this week, I encountered a patient who, as he told me, was not feeling well. He gave me a history of having been wet by the rain one day, and then having been exposed to the sun the next day, and then having flu-like symptoms the next day. Went and got tested along with the girlfriend and daughter who lived in the same house. Both the girlfriend and the daughter were positive, PCR positive. He was PCR negative. Symptoms persisted. He went to Sunny Crest. I believe he had a positive rapid test, a subsequent negative PCR test again. But you know what clued me in, apart from the fact that he had two close contacts who were PCR positive is that he had a very distinctive symptom of COVID-19, which is not commonly known. Now, you would often hear that COVID-19 is distinguished. Of course, it's not unique to it, but it's distinguished because if you have sinuses or a cold, you can also get these symptoms: loss of smell, loss of taste. He did not have loss of smell or taste, but do you know what he had? He had altered sense of smell and taste. In other words, things that normally would taste pleasant and appealing to him taste awful. For example, you go to eat some scrambled eggs and it tastes like garbage. This is the symptom that he was having. It's called Aurosmia. So if you note this symptom, even if you don't lose your sense of smell or taste, and you get this horrible alteration in your sense of taste or smell, then alarm should go off. You should have a very high index of suspicion, especially if you have close contacts who were positive. But even if you don't, have a high index of suspicion and get tested. Because you know what? We did an antibody test on this gentleman for COVID-19, and he came back positive for IgM and IgG antibodies, suggesting that he has, or rather, he has a current infection going on.
Dr. Greenidge, if I can make a comment on that, please. You're correct in that, but I don't always refer to it as false negative. But in fact, there are times when there's not enough virus in the system for the PCR test to actually detect a positive test, because we are actually looking at a cutoff of 35 in the CT value, as you would realize. And therefore, some persons might have had the virus and gone for testing after, because now you're seeing that there are antibodies. So therefore, at that particular time, he might have had the test for a long time past the 14-day period and is no longer being detected by the PCR, but he does have antibodies. So it means at some stage he would have had the virus. And then also some people are exposed and they go for the first test and the first test is negative. That's not necessarily a false negative, but they're not having enough of the virus yet for it to be detected. And then when they go for the second test, which is the 5 days after the second test is positive. And that's what we've been seeing since 2020 and now 2021. A lot of the first tests are usually negative, and some people decide, okay, I have a negative PCR and I'm not going back. But that doesn't make sense. If you're exposed and you have the first test that's negative, then 5 days or so after, you go and you get your second test. And most of the time, if you're really exposed, then that second test is usually positive. And there are actually some people that even have to get a third test before they get a positive result. It just depends on the amount of virus in your system at the particular time. Thanks.
Thank you very much. That's quite true. Thank you.
Well, okay, and Dr. Greenidge, that's it?
Until next time.
Okay, so we want to thank God very much for using you in such a way that it would have educated us regarding this deadly disease. And we are going to pray and ask God to give us wisdom. We need wisdom at this time as to how to function relative to our environment and those things that are going on in our bodies, all right? So pray with me as we end this program. Father in heaven, we thank you very much for using your manservant in such a way that he can break things down, even though using medical terms. that we can get a picture as to what is actually going on in our bodies, where virus is concerned and how tricky this virus is. One thing we know about this virus is that we don't know anything at all much about it. And therefore, we are asking that you would give wisdom, knowledge, and understanding as to how to deal with it and how to advance on in our Christian walk in preparation for the coming of Christ. We thank you very much for hearing our prayer. In Jesus' name, amen. Praise the Lord. So again, I thank you all very much, and I'm looking forward to seeing you next week at 6, where Dr. Greenidge will continue this program as he goes deeper into the symptoms and also techniques that you can use for early treatment, even as you have early detection. Remember, early detection, early treatment save lives. God bless you. Have a wonderful evening.